Making Sense of Sellar Region Pathology, Image-Based Diagnostic Algorithm. Amar Chowdhury, M.D. Rajesh Gupta, Maryland. Luboslav Warok, Do. Alexander Filatov, Maryland. Robert Peister, Maryland. Lev Benkiev, Do. Eid 69. SN 960. Disclosures. No relevant disclosures. Objective review of anatomy of sellar and parasellar regions. Review common indications for imaging of the pituitary gland. Discuss imaging techniques of the pituitary gland. Review common pathology of the pituitary gland and the adjacent structures. Image-based diagnostic algorithm. Sphenoid bone anatomy, pituitary fossa, tuberculum sayi. Optic nerve canal. Chiasmatic sulcus. Superior orbital fissure. Anterior clinoid. Posterior clinoid. Greater wing of sphenoid. Lesser wing of sphenoid. Planum sphenoidale, pituitary gland anatomy. Lies within sella turcica. Composed of two major parts. Anterior lobe, adenohypophysis. Pars distalis, bulk of the gland, hormone secretion. Pars intermedia. Pars tuberalis. GH, TSH, ACT, prolactin, LH, FSH. Posterior lobe, neurohypophysis. Vasopressin, oxytocin. Laterally bounded by cavernous sinus. Optic chiasm superiorly. Diaphragm ocella. http://mistadx.com, embryology blood supply. Posterior lobe. Neural primordia. Outpouching from the third ventricle. Anatomic extension of the CNS. Specialized glial cells, pituocytes. Anterior lobe. Derives from the Aurolectoderm rathkes pouch. Gives rise to pars distalis and tuberalis. Posterior lobe supplied by inferior hypophyseal arteries. Anterior lobe. Little or no arterial supply. Portal venous system from the pituitary stalk. Venous blood from posterior pituitary. Humoral regulation from the hypothalamus, posterior pituitary, and substances in the peripheral circulation. Indications for imaging. Imaging of the pituitary radial clin NM49, 2011, 549-571. Imaging. Mr. Protocol. Imaging Mr. Demonstrate relationship to chiasm and cavernous sinus. Distinguishing solid, cystic, and hemorrhagic components. Vascular structures. Anterior lobe is iso-intense to brain on T1Y and T2Y. Posterior lobe is bright on T1Y and lower intensity on T2Y. Imaging enhancement size. Children, less than 12 years, 6 mm, upper surface flat or slightly concave. Puberty, 10 mm, upper surface convex, more striking in females. Young adult. Male, 8 mm. Female, 9 mm. Pregnancy, 12 mm. Older adult, greater than 50 years, gradually decreases in size. Imaging CT calcifications. Bony septa assessment for transvenoidal pre-surgical planning. Involvement of the adjacent osseous structures. Contraindications to MRI, location-based algorithm. Common pathology. Location-based algorithm. Parasellar. Suprasellar. Enhancing. Craniopharyngioma. Germ cell tumors. Meningioma. Aneurysm. Non-enhancing. Hamartoma. Pituitary stalk. Lymphocytic hypophysitis. Langerhans histiocytosis. Sarcoid. Mets. Ectopic posterior pituitary. Lipoma. Clivus. Chordoma. Nasopharyngeal carcinoma. Chiasm. Glioma. Sellar. Expanding sella turcica. Pituitary macroadenoma. Non-expansal. Intensity. Hyperintense T1. Rathke's cleft cyst, if protein. Dermoid cyst, children. Hyperintense T2. Meningioma. Rathke's cleft cyst. Hypointense T1. Pituitary microadenoma. Hypointense T2. Pituitary apoplexy. Macroadenoma. Microadenoma. Rathke's cleft cyst. Craniopharyngioma. Langerhans cell histiocytosis. Germinoma. Apoplexy. Empty cella. Hypophysitis. Meningioma. Opticlioma. Hamartoma. Arachnoid cyst. Epidermoid. Lipoma. Ectopic posterior pituitary bright spot. Aneurysm. Sarcoid. Base of the skull tumors. 55-year-old female with history of glaucoma patients was followed with serial visual field testing. The visual field deteriorated and began to show a bitemporal hemianopsia. Core T2Y. Sagpre T1Y. Corpre T1Y. Corpost T1Y. Macroadenoma. Similar imaging characteristics as microadenoma. Normal pituitary tissue often not identified. Expands the cella. Snowman appearance where the waist is the imprint from rigid dura. May extend into the suprasellar region and compress the chiasm. May invade the cavernous sinus. 19-year female with hyperprolactinemia. Dine-core pre-T1Y. Dine-core post-T1Y. Approximately 10% to 15% of all intracranial neoplasms. Most common Sellar tumor. Benign. Classified based on size. Microadenomas less than 10 mm. Macroadenomas greater than 10 mm. Clinically classified based on endocrinological activity or lack. Functional pituitary adenomas usually secrete single hormone. Prolactin most common, followed by GH and ACT. Microadenomas are hypovascular compared to normal pituitary tissue. Microadenoma. Invasive pituitary adenoma. Clival invasion is rare but potentially significant complication of pituitary adenoma. Difficult to detect on MR imaging, easily seen on CT. Risk factor for clival invasion. Female sex. Large tumor volume. Null cell subtype. Larger tumor volume correlated with null cell subtype, Mann-Whitney U test, p equals 0.006, incidence of clival invasion, p less than 0.001, and extent of clival invasion. Clival invasion was associated with a significantly higher ratio of operative complications and recurrence. After we corrected for multiple correlations, the most significant independent risk factor for clival invasion was female sex, or equals 3.62, p equals 0.014, multinomial logistic regression, followed by large tumor volume, or equals 1.08, p less than 0.001, and null cell subtype, or equals 5.47, p less than 0.001. Larger tumor volume correlated with null cell subtype, Mann-Whitney U test, p equals 0.006, incidence of clival invasion, p less than 0.001, and extent of clival invasion, p equals 0.038. Clival invasion was associated with a significantly higher ratio of operative complications, 15.63%, Chi2 equals 7.067, P equals 0.008, and recurrence, 57.14%, Chi2 equals 10.739, P equals 0.001. 40-year male with progressive visual decline in the right eye over several weeks, presence with rapid visual loss, slight droopiness of the right eye, and severe headache. Pituitary adenoma with hemorrhage. SAG-pre T1Y. AX T2Y. Corpus T1Y. Pituitary apoplexy. Lack of direct arterial supply to anterior pituitary lobe makes it susceptible to ischemia with or without hemorrhage. Clinical syndrome. Headache. Visual changes. Ophthalmoplegia. Mental status change. Underlying adenoma is often present. Empty cellopatulous diaphragmus AE aging pseudotumor cerebri. Infarction. Surgery. Radiation therapy. Hypopituitarism is rare. 25-year female with headaches. SAG-pre T1Y. SAG post T1Y. Cor T2Y. Corpus T1Y. Derived from Rathke's pouch, primitive or ectoderm. Lined by single layer of columnar or cuboidal epithelium. Frequently asymptomatic. May present with bitemporal hemianopsia or pituitary dysfunction. Intracellular and non-invasive. May contain serous or mucoid material. Serous, hypodense on CT, T1 hypointense and T2 hyperintense. Mucoid, hyperdense on CT, T1 hyperintense. Rarely calcify. May demonstrate mild enhancement of the wall. Rathke's cleft cyst. Papillary craniopharyngioma. AX-pre T1Y. AX post T1Y. AX T2Y. SAG post T1Y. 73-year female with headache and visual disturbance. Papillary craniopharyngioma. 8-year female presented with progressive double vision and papilledema. Left CNV palsy. Adamantinomatous type craniopharyngioma. Corpus T1Y. Histopathologic types of craniopharyngiomas. Benign neoplasm arising from squamous epithelial remnants of Rathke's pouch. Tend to recur and invade adjacent structures. Commonly present with headaches. Endocrine dysfunction. Visual disturbance. Bimodal age at presentation. 5 to 14 years in children. 65 to 74 years in adults. Usually suprasellar, but may extend into the sella. Prechiasmatic, visual disturbance. Retrochiasmatic, increased ICP, compression of the hypothalamus and protrusion into the third ventricle. Adamatous. Squamous papillary. Location. Suprasellar. Intracellular/suprasellar or suprasellar. Age. Children, occasionally adults. Adults. Tissue structure. Predominantly cystic. Predominantly solid. T1 without contrast. Hyperintense cysts typical. If ever, hypointense cysts. Shape. Lobulated. Spherical. Incase vessel. Yes. No. Tumor recurrence. Plus. Calcifications. Imaging characteristics. Vary in size and composition. Cystic and or solid. CT. Enhancing solid/cystic mass. Calcifications plus/ MRI. T1Y, vary intensity depending on contents, proteinaceous debris, cholesterol, and hemoglobin. Enhancement of the solid component. T2Y, predominantly hyperintense. Calcifications are hypointense on all pulse sequences. 25-yo female with history of meningioma. SAG pre-T1Y. SAG post-T1Y. Core post-T1Y. Meningioma may arise from the tuberculum sayi, anterior clinoid, diaphragm sayi, planum sphenoidale, cavernous sinus, and upper clivus. Commonly present with progressive visual symptoms. CT, hyperdense mass with homogeneous enhancement. MRI-T1 isointense, T2 iso hyperintense, avid enhancement. Distinguished from pituitary adenoma by normal size of the sella turcica. Identification of the normal pituitary tissue. Can invade cavernous sinus with narrowing and/or occlusion of eca. Hyperostosis. AX-T2Y. AX post-T1Y. 6-yo male with progressive left eye vision loss over a year. AX pre-T1Y. Core pre-T1Y. Core post-T1Y. Core post-T1Y. Optic glioma. Tumor of childhood. Majority benign and slow growing. Often associated with NF1. Separate from pituitary gland. T1 isointense and T2 hyperintense with variable enhancement. Presence of cystic component suggests JPA. Core T2Y. 21-yo male presented with progressive vomiting, polyuria and polydipsia for months, progressive loss of his peripheral vision in both eyes, bitemporal inferior quadrant synopsia, panhypopituitarism and diabetes insipidus. HCG serum, BHCG CSF. SAG T2Y. SAG pre-T1Y. SAG post-T1Y. Core post-T1Y. Germ cell tumor. Lesion of childhood and young adults. Mr. Findings. Germinoma is the most common type. T1Y, iso/hyperintense to gray matter. 20% in sellar/supercellar region and remainder in pineal region. T2Y, iso/hyperintense to gray matter. Calcification, hemorrhage, rare. Commonly present with DI, hypopituitarism, and optic chiasm compression. DWI, restricted diffusion due to high cellularity. CT, hyperdense and homogeneously enhancing. Strong, homogeneous enhancement, plus minus CSF seeding, plus minus brain invasion, lymphocytic hypophysitis. 23-yo female with hypopituitarism. Core T2Y. SAG pre-T1Y. SAG post-T1Y. Core post-T1Y. Lymphocytic hypophysitis. Inflammatory disease of the pituitary. Can involve infundibulum. Young women during late pregnancy or postpartum. Imaging shows enlarged enhancing pituitary gland and thickened infundibulum. May regress spontaneously or with steroids. Hamartoma of the tuber cinereum. 2-yo female with gelastic scissors consisted of laughing, turning her head to left side and tonic motor activity of the extremities. SAG pre-T1Y. SAG post-T1Y. Ax flare. Ax T2Y. Hamartoma of the tuber cinereum. Congenital non-neoplastic heterotopias. Known cause of precocious puberty due to secretion of LH-releasing hormone. Gelastic seizures may be related to connection of the lesion with limbic system or possibly presence of other abnormalities, callosilogenesis, heterotopias, and microgyria. Just anterior to mammillary bodies. T1 isointense and T2 hyperintense to gray matter. Do not enhance, calcify, or contain cysts. Langerhans cell histiocytosis. 13 Yo male presented with diabetes insipidus. SAG post T1Y. Core post T1Y. Langerhans cell histiocytosis. Proliferation of Langerhans cell histiocytes forming granulomas within any organ system. Etiology, uncertain, inflammatory, left-right arrow, neoplastic. Peak age at onset 1 year, isolated, 2 to 5 years, multifocal disease. Common presentation, DI, plus minus visual disturbance, plus minus hypothalamic dysfunction. On imaging thick enhancing infundibulum, absent posterior pituitary bright spot. Lymphocytic hypophysitis. 23 Yo female with hypopituitarism. Core T2Y. SAG pre T1Y. SAG post T1Y. Core post T1Y. Lymphocytic hypophysitis. Inflammatory disease of the pituitary. Can involve infundibulum. Young women during late pregnancy or postpartum. Imaging shows enlarged enhancing pituitary gland and thickened infundibulum. May regress spontaneously or with steroids. Granulomatous disease. Sarcoid, DB, Wegener etc. Cranial nerve involvement. Cannot be differentiated by imaging. Sarcoid may present with sellar or suprasellar mass and masquerade as pituitary adenoma or meningioma. Epidermoid cystic lesion filled with keratin. AXT2Y. AX flare. SAG pre T1Y. AXDWI. Cystic lesion filled with keratin. Signal characteristics are similar to CSF on T1 and T2, however not flare. Show restricted diffusion. Usually do not enhance. Insinuate throughout the suprasellar region. Lipoma characterized by T1 hyperintensity due to fat. Lipomas are usually circumscribed. Teratomas and dermoids can grow large and compress adjacent structures. Teratomas may contain calcification or ossification. SAG pre T1Y. Incidentally found lipoma. Patient was imaged for headache, 58 Yo male with jerking motions during sleep and progressive memory loss. No visual changes or endocrine symptoms. SAG post T1Y. Axnect. SAG pre T1Y. Chordoma. Imaging. CT. Soft tissue mass with bone destruction and calcifications. MRI. T1Y, iso-intense to brain parenchyma with hypointense calcifications. T2Y, hyperintensity is a rule. Enhance. Core T2Y. Metastasis 53 Yo female with history of breast ca AX pre T1Y AX T2Y. SAG post T1Y. 53 Yo female with history of breast ca. Aneurysm 51 Yo male with acute onset of headache and left CN3 palsy. NECT. AX pre T1Y. Core post T1Y. AX T2Y. 51 Yo male with acute onset of headache and left CN3 palsy. Lot Lieutenant CCA. AP Lieutenant CCA. Conclusion location Sellar intensity iso-intense T1 hypo T2. Subacute, hyper T1/T2, compavadenoma. Pit apoplexy. Hyperintense T2. Gender. Both. Pituitary macroadenoma, greater than 10 mm, mild enhancement. Female. Enhancement. Intense. Can be suprasellar. Meningioma calcify. Rare. Rathke's cleft cyst. Hypointense T1. Pituitary microadenoma, less than 10 mm, hypoenhancement. Hyperintense T1. Male. Dermoid cyst children calcify. Rathke's cleft cyst if protein content adults. Eccentric mass, cavernous carotid aneurysm. Suprasellar. Heterogeneous. Craniopharyngioma. Solid, enhances. Cystic, high T1/T2. Bimodal H. Calcify. Homogeneous. Uniform enhancement. Germ cell tumors. ISO T1/T2. Pituitary stalk. Young age. Histiocytosis, eosinophilic granuloma. Hypo T1/hyper T2. Mets enhances. ISO T1/T2. Sarcoid enhances female. Lymphocytic hypophysitis. Chiasm/hypothalamus. Yes. Hyperintense flare. ISO T1/hyper T2. Young age. Glioma. No. Floor of third vent. Hamartoma.